Good morning. Today we begin the public hearings into Module 3, investigating the impact of the Covid-19 pandemic on the healthcare systems of the 4 nations of the United Kingdom. The hearings will last for 10 weeks in all, divided into 2 sessions. We shall take a 2-week break in mid-October. This will allow counsel to the inquiry and for the core participants to ensure they are as fully prepared as they can be for the second session. We have a huge amount to get through, and the only way we can do that in the time I have allowed is by strict adherence to the timetable. I apologise in advance to those who would like us to spend more time examining particular issues in these hearings. I understand their concerns. But as I've said before, the longer any set of hearings take, the longer the delay in making recommendations, and the longer the delay in investigating other important modules, such as the impact on the care sector and children and young people. In all our modules, we start the hearings with an impact film to remind everyone why we are here. We decided for this module to divide a longer film into 2, because with a break in the middle, we wish to ensure that those following our proceedings do not lose sight of the fact of why we are here. We shall show one part of the film at the start of each session. I wish to emphasise that the fact that the first part to be shown today features predominantly healthcare workers rather than the bereaved does not in any way undermine the importance of the second part of the film. The order was chosen simply as a way of introducing the evidence we are about to hear. And that evidence, I emphasise, will include as the first 2 witnesses bereaved family members. I am very grateful to all those who contributed to making the films. I can only imagine how difficult it must have been for them. As with the previous impact films, these 2 are extremely moving, and there will be those who will find them too distressing to watch. I will pause in a moment to allow those who are in the hearing room who wish to do so to leave for a few minutes. The film lasts about 20 minutes, and those who are following online to press mute or exit the live stream. After the film has been played, we shall reassemble, and Ms. Jack Carey, King's Counsel to the inquiry for this module, will begin her opening submissions. She will set the scene, provide some background, and explain the issues we shall be examining in this module. So if those who would like to leave the hearing room or press pause, please do so now.
I was a student paramedic at the start of 2020, so I was coming to the end of my training as we were starting to get the whispers of this respiratory condition.
We started to get people coming through who were having anosmia, where you can't smell. But again, we still hadn't put 2 and 2 together and realised it was COVID. But that was early, mid-January that was happening.
I was in a surgical rotation when it really hit. There was no surgeries, so there wasn't any patients, and there's no electives, right? Everything got cancelled.
There was a lot of kind of uncertainty, and people didn't quite know what to do. I, along with a lot of people, just felt, I suppose, very vulnerable, particularly, being in sort of frontline kind of staff.
Very early on, before national protocol here was introduced of lockdown, we kind of saw that coming and thought, okay, we need to start trying to prepare and get things in place. Literally a day or 2 before. It was quite an intense period, pretty much overnight. Had to get all of that installed, and very little support in terms of just that advice from a health and safety point of view at the beginning.
All of the things that we had usually done in our practice had to change overnight. We were kind of going to work every day knowing we were being exposed to COVID, but we had nothing there was no support at all.
So my first shift qualified was May, 1st of May, and I was due to actually start qualified in October, so it was nearly 6 months earlier than it should have been. There was a bit of sitting around and we felt a bit anticlimactic because the messaging was working, don't call us if you don't need us. But the side consequence of that was people weren't calling us until it was beyond help, or people weren't calling us because they didn't want to worry us with other conditions. You know, it wasn't just COVID that we were trying to deal with.
There's loads of people that you'd see and you'd think, why didn't you come sooner? Like, there are other diseases and other illnesses and other things that are still going on. People were so afraid to come into the hospitals.
Having had nothing, suddenly we were getting maybe 50 pieces of information every day through email that we had to... Where were we going to find time to even read these pieces of information? What we had to do, how we had to triage. We had people who had cancer, we had people who had COPD, we had, you know, lots of ill people who couldn't see us because we weren't allowed to see them overnight.
His eyesight was getting worse and worse and worse, and I says, Craig, there's something not right here. Craig had a previous brain aneurysm when he was 21. So I phoned 6 different opticians and asked them for it to be seen, and I was told no, there was no appointments. And they said, has he got a headache? I said, no. They says, well, we can't see him. No, that was a receptionist triaging a patient on a phone. He didn't want to go near a hospital. He didn't want to go and bring anything back to me, and he collapsed at work. And he died on the 3rd of September with a brain aneurysm. The hospital consultant, the neurologist, told me, Caroline, Craig didn't die of COVID. He died as a result of COVID because he couldn't get seen. So because he didn't have a headache, they played lottery with his life and he died. They were just so unprepared.
We didn't have any PPE at all at that point. We slowly started getting simple kind of, you know, just the masks that everyone wears out here, nothing that was proper.
They didn't give access to the FFP3 masks to the pharmacy sector, it was just the kind of paper masks. How effective are they?
So we were going in to see patients in the paper masks and starting life support on these patients, but we were unable to insert airways and manage their oxygenation until someone in full respiratory protection arrived. Now that process took up to 3 or 4 minutes to get fully dressed and fully in that respiratory protection, and by the time that we'd arrived and then someone had arrived to then put the respiratory protection on, they were often beyond help before we'd even started. We'd done back-to-back cardiac arrests of patients under 60. And it was a man that he would have been 34. And I'd been to see him 2 days before, and he wasn't sick enough to take to hospital the day that I'd seen him. He was sick enough to go to hospital, but for the hospital at the time, he was not sick enough at that point. There was no space for people that were in that horrible middle ground of poorly, but not poorly. I can't drive past that house without seeing it. And I'm not alone in that story. The amount of people that we went to 2-3 days before that were poorly, and in any other day, any other week, would have probably been rushed to hospital, put in the resuscitation room and aggressively managed and taken to intensive care. The only way that you can go home at night is knowing that you're not going to save everybody, but knowing that there are people out there that we probably could have. Had the system been more ready, had the money been spent maybe more effectively, had they not been running at 105% capacity before this happened, then maybe this person would have been alive. Maybe this person would be able to tell his story.
We also decided we had to do lots more home visits. Most people, it was better for us to go to them than them to come to us. So we're sort of standing on balconies trying to put on, you know, don and doff our PPE, and before we went into a house which was COVID infected. I can remember going and seeing one of my patients who had rung me in the morning to say he was sick. And I said to him, I think you need to go to hospital now. He said, I'm not going to hospital. I went to see him on my way home into the room where he'd been all day dying. I did get him into hospital that night, but he was dead by the morning.
I was taken straight away into intensive care, and they thought I was going to die at that point. I remember lying in bed and the doctor standing by the side of my bed saying, will you sign a piece of paper to let us put you to sleep? So I said, yes, will I wake up? And the doctor said, well, we've got a 50-50 chance. And then I said, if I don't sign, he said, well, 0. I am a different person, and my body is different from before. You see, I have permanent damage from COVID. So it's like another kind of long COVID. So my eye that I can't really see with, my ear that I can't really hear with, my numb toes. I mean, people in my situation who maybe are in their 20s, 30s or 40s, perhaps this is more bewildering than for me. This may well have a huge knock-on effect health-wise. We just don't know at the moment. You know, a big change has happened, you know, and it can't just be solved by saying there is this virus and this is what happened to people's bodies, the end. It can't be solved that way.
Obviously, at the time, you're very anxious, very scared. When you've got your nearest and dearest near you, you're very worried about that and passing things on. And again, the responsibility you've got towards your colleagues.
If you don't know if the PPE is appropriate for the threat that we're facing, tell us, and then we can mitigate it. I was out with a colleague, and I had a patient was coughing, and there were visible droplets coming off of her, and she coughed down onto my face, and I remember it reaching the top of my nose, and I tested positive 2 days later. That was the first time I got it, and at the time my wife was 6 months pregnant, and I didn't know if I was going to kill her. I didn't know if I was going to kill my unborn baby. We tried so hard to play the game. We tried so hard to make sure that people were safe.
So there was a call out for people to help triage on 111, which was basically calling back people who thought they had COVID. We were making decisions about whether they were ill enough to go to hospital, essentially, because we're trying to stop everyone going to hospital. There was no way hospitals were going to cope if everyone who had COVID went to hospital. It was very difficult. It was horrible because I knew I might be making wrong decisions. You know, I knew I might be leaving someone at home and telling them they shouldn't go to hospital when they should.
You know, I think it's also kind of really exposed some of the big structural inequalities that exist in society. You know, whether it's poverty and in terms of ethnicity, and probably also, I think, now just really laid bare how fragile the NHS is.
It just kind of highlights like the institutional and systemic like racism that's like built into, you know, places like the NHS, because it was all black and brown people that were the most affected and the first affected as well. That's another thing that kind of like affects training and everything else, because already you know that people are looking down on you in a certain way. And you can tell, I mean, like sometimes it's explicit, sometimes it's implicit, and there's always a baseline level that you just have to unfortunately accept, you know, you just have to accept it.
In my intensive care ward, nurses were going from bed to bed, which is absolutely forbidden. You have one nurse per patient 24 hours a day. There weren't enough nurses. When I look in my patient diary, it says, physiotherapist, I came in to help. Speech and language therapist, I came in to help. And they weren't trained to be ICU nurses who are ready for bereavements, ready for people dying, boom, just like that in front of you. And so they were traumatized. And there are people still recovering from this. I've spoken to nurses who've not been able to go back.
When I reflect on it now, what I really believe is that had the NHS been in a better place than where it was when this hit, we would have managed it better.
So just think about the healthcare workforce that you are developing. You've like stopped teaching, you don't have as much of that sort of, you know, learning from the seniors. Everyone's a lot more isolated. Just the standards have dropped ridiculously.
We see it now, you know, I'm 4 years post-registration and I'm burnt out. My colleagues are burnt out. The moral injury that my profession, my colleagues have sustained is not to be understated. The compassion fatigue. More colleagues than I'd care to mention have gone part-time, have found other jobs. Some have left the profession entirely, some have left healthcare entirely because of that 2-year period was too much.
Thank you very much. Could we alert the people watching who've left the hearing room, please, to come back? Sorry, I think I said 20 minutes. I gave the wrong time estimate. Apologies to everybody. I'm sorry, I gave the wrong time estimate, so for those who are returning. Thank you. Ms Carey, King's Counsel.
Thank you, my lady. On the 23rd of March of 2020, when the then Prime Minister Boris Johnson told the country to lock down, the broadcast included the following phrase: stay at home, protect the NHS, save lives. And the focus of the inquiry's Module 3 hearings will be on some of those words and the ultimate questions: did we protect the NHS? Did we save lives? And perhaps as importantly, why did we need to protect the NHS, and at what cost? What cost, for example, to those people who did not have COVID but rely on healthcare systems to treat non-COVID conditions? What cost to the physical and mental toll on healthcare workers? What cost to those who could not visit loved ones, who had to shield, to those now living with long COVID? And what cost, my lady, to the families of all those patients and healthcare workers who died? As my lady knows, between March 2020 and February of 2022, death certificates show that there were 668 deaths involving COVID registered in the UK. The death certificates record the places of death across all 4 nations, and it is in fact between 60 and 70% of people who died from COVID did so in a hospital. The first healthcare workers who died were on the 25th of March of 2020. And the impact of dealing with so many deaths is just one of the many topics covered by Module 3's Every Story Matters healthcare record. That report analyses and brings together over 32,000 stories related to UK healthcare systems, and includes contributions gathered from 450 interviews conducted across the UK with people impacted by the pandemic, along with hearing from those who engaged with the discussion groups. That report includes quotations which powerfully depict the daily realities of life and death within the healthcare systems. And let me just quote 2 at the outset. A hospital porter said this: "The fact that people were in ITU and they were alone was horrible, because you could just see it in their eyes. You could see it in the eyes of the staff, the nurses, the doctors. At the height, it was a really horrible place to be. That was probably the thing that will stick with me the most, is that so many people died on their own, or so many people died with only one family member around them, which was horrific." A hospital cleaner said this to Every Story Matters: "I was cleaning her room, and I remember. She took off her mask to me. She was like only 24, 25. I'll never forget her. And she says, 'I thought Covid-19 wasn't a real thing.' She went, 'But honestly, it's killing me.'" That cleaner broke down when he spoke to Every Story Matters and said this: "It makes me quite emotional. Actually, it was sad." It is not possible or practical for me to reflect in this address the many thousands of stories that people have shared with Every Story Matters, but the report itself will be published today at noon on the inquiry's website, and it is hoped that it is a lasting account of the very real human impact that the pandemic had. There will be similar reports for other modules, and I know my lady would wish to encourage as many people as possible to participate in this vital part of the inquiry's work. And so to Module 3. This opening is an introduction to just some of the topics and issues that you will be asked to consider in Module 3. And can I ask, please, that the scope of Module 3, ending 474319, is put up on screen. Time doesn't allow me to go through each and every one of the particular aspects of Module 3 that will be examined. It is necessarily broad. It is undoubtedly ambitious, covering as it does the impact on primary, secondary and tertiary care in all 4 nations of the UK. The time frame for the examination of this module's purposes is the 1st of March 2020 to the 28th of June 2022. We've called it the relevant period, and you may hear me refer to it as such throughout. Primary care, as you know, includes but is not limited to general medical practice and community pharmacy. Secondary care includes planned or elective care that usually takes place in hospital, the emergency and urgent care. It includes 999, ambulance services, emergency departments, acute hospital admissions, and some mental health services. And tertiary care, my lady, includes highly specialist care provided to patients who've been referred from primary or secondary care. In the context of this module, this may include treatment for more complex cases of colorectal cancer, inpatient children's mental health, and specialist intensive care. And you can see set out there, and it's on the inquiry's website, the 12 different areas that the module will examine over the next 10 weeks. Whilst formal in its drafting, at its heart, you may think at a more fundamental and human level, the sorts of questions that may need to be considered in Module 3 include these. Why couldn't I see my GP? How was I protected from getting COVID-19? Where was my ambulance? Why was my treatment delayed? Did I receive the type of care I needed? Did my loved one? Why couldn't I visit my loved one in hospital? Were healthcare staff protected, looked after? Or perhaps more simply, was I safe at work? What was done to help with the long-term consequences of COVID? These will all be aspects of the evidence heard in Module 3, which may overlap with and indeed complement work being done by other modules, in particular Module 6, examination of the pandemic on the adult social care sector. To take an obvious but hugely important example, issues relating to the discharge decisions of hospital patients into care homes without testing, well, they are matters important to both modules. And Module 3 will look at the impact of the decision as it affected hospital capacity. Module 6 will look at the impact of the decision on the care sector. In order to examine these matters, Module 3 has requested over 250 witness statements, obtained 10 separate expert reports, commissioned independent research project looking at decisions made by health workers about escalation decisions. I'll return to that in a moment. The inquiry's also gathered evidence from a number of spotlight hospitals across the UK to help examine what was going on the ground. And taken as a whole, the spotlight statements provide evidence about matters such as the impact of significant staff shortages on staff to patient ratios, the physical and emotional toll on staff, the significant efforts made by those hospitals to increase their capacity for intensive care unit beds at pace, and the serious and wide-ranging issues with the suitability and reliability of PPE that was supplied. And my lady may hear of some innovative ways that staff and management filled those gaps. In total, over 16,500 documents have been disclosed. It amounts to over 225,000 pages of evidence. And that work has resulted in a huge body of evidence. Many of the statements run to hundreds of pages from which you'll be able to draw your conclusions and, importantly, make recommendations to help the healthcare system's response in the future. I know that you will be assisted by the 36 core participants and their questions and submissions. The reasonableness or otherwise of actions and of decisions taken by those responsible for the healthcare systems will be an important consideration for your ladyship. And I know that you will not be judging decisions made with the benefit of hindsight. Hindsight's invariably 20/20, and so would not be an accurate or fair way to consider unprecedented decisions that had to be made quickly in highly pressurised environments. Many of the witnesses will tell you that there were no good decisions. Rather, it was a case of what is the least bad decision. At the outset, it should be noted that when the government departments were asked to provide statements, they were asked to identify which individual would be best placed to provide the statement and who was able to speak knowledgeably about the matters set out. Accordingly, the inquiry is able to draw upon a wide range of witnesses, some of whom were in post throughout the relevant period, some of whom may have been in post for only part of the relevant period, and some who've now taken up the role, heading up the organisation, and so can bring a slightly different perspective as to where we are now in 2024. Irrespective of which camp the witness falls into, witnesses have been asked to reflect on what worked well, as well as what did not. And for those giving evidence, may I make this plea? Please be prepared to assist in real practical terms when asked about recommendations that your ladyship may wish to consider. Whilst it's clearly important that in Module 3 the inquiry considers what decisions were taken and why so that lessons can be learned, Module 3 has an important forward-looking perspective, as will be reflected in many of the questions during this public hearing. At the outset, it may assist if I briefly outline the structure of the healthcare systems in each nation and the key individuals from who you will be hearing. As health is a devolved matter, there are 4 distinct health systems within the UK. And whilst it may be an oversimplification and the names and terminology may vary between the nations, it may be helpful to think of the structure in each nation in this way. The government minister sets the strategy, the respective government department devises the policy to deliver that strategy, and then each nation has its own bodies, organisations to put that policy into practice. This map, and I'm going to ask please that INQ 474319 page 3, thank you, is put on screen, may help give an overview of the landscape of the healthcare systems during the pandemic. Now, some of the names have changed, and indeed some of the numbers, in particular the clinical commissioning group numbers, have changed. You will see that in England there are 135, or there were, I should say, 135 clinical commissioning groups, representing the figure in 2022 to 2021. There were 7 local health boards. There are 5 health and social care trusts. There is, in fact, a 6th trust, the Northern Irish Ambulance Trust, but we haven't depicted that on the map. And there are 14 geographical health boards in Scotland. So turning briefly to England. In England, the Department of Health and Social Care, DHSC, supports and advises ministers and the Secretary of State of Health and Social Care. Now, the pre-COVID understanding of roles and responsibilities regarding pandemics in DHSC and a number of bodies is undoubtedly a matter you're going to be hearing about, and it might be more easily understood by reference to the diagram on page 4, please. And if we could just enlarge it. These are terms with which my lady will be familiar and will become more familiar throughout. One can see DHSC sits at the top. There was the Pandemic Influenza Preparedness Board and Programme. And then under that, Public Health England, NHS England and NHS Improvement. Then down to the CCGs, the NHS providers, and a number of expert advisory committees. And I know you'll be familiar with the work, for example, of NervTag and the other committees set out there. DHSC is headed by its permanent secretary, Sir Christopher Wormold, who I know has given evidence in earlier modules. And the permanent secretary supports the government minister, who's the head of the department, who is in turn accountable to the Prime Minister and others in Parliament for the department's performance. During the pandemic, the Secretaries of State were Matt Hancock until his resignation in June 2021, when he was succeeded by Sir Sajid Javid. And the Secretary of State has a statutory duty to take such steps as he considers appropriate for the purpose of protecting the public in England from disease or other dangers to health. And he has a power to take such steps as he considers appropriate for improving the health of people of England. The principal way he does that is through Public Health England, with both the Department and Public Health England having responsibilities for planning for and indeed managing the response to emergencies and health protection incidents. On the 1st of October in 2021, Public Health England was replaced by the UK Health Security Agency, UCSA as it's sometimes referred to, as a part of wider government restructuring. And you will be hearing from UK HSA's CEO, Professor Dame Jenny Harries, and its Chief Medical Advisor, Professor Susan Hopkins. One can see on the screen there reference to NHS England. NHSE, as it's often shortened to, commissions healthcare services and has responsibility for arranging the provision of services for the purposes of health service in England. For the majority of the pandemic, NHSE worked together with NHS Improvement. And so many of the documents we will look at will make reference to both NHSE and NHSI. The chief executive officers of NHSE were Sir Simon Stevens until July 2021, and then Amanda Pritchard, who was in fact the chief executive of NHSI. And its board members include Professor Stephen Powis, who is the National Medical Director. You'll be hearing from the latter two witnesses, both of whom have provided lengthy and comprehensive witness statements. And my lady may recall that the map referred to 135 CCGs. They are responsible for planning and commissioning health services in local areas using the funds allocated to them by NHS England. There are then a number of services provided by the NHS trusts, and a trust indeed can run multiple hospitals and community sites. It is NHS England who is responsible for setting an emergency preparedness resilience response strategy, or EPRR, for the NHS. For the purposes of this relevant period, NHS England's EPRR framework from 2015 applied. And that framework describes in terms the level of response and coordination required, which may change as the incident evolves. And so can we call on screen, please, page 5. This is the EPRR framework in place in England, various different levels set out there. And the incident level informs how the EPR framework will respond. Throughout the relevant period, the NHS in England was either at a level 3 or level 4. And in fact, the NHS in England spent 421 days at level 4 between the 30th of January 2020 and the 28th of June 2022. And you can see there that level 4 essentially means that NHS England National Command and Control will support the NHS response, and it's NHSE's job to coordinate the NHS response in collaboration with local commissioners. Now this, my lady, is a framework specific to England. You will hear that each nation had a different approach to EPRR frameworks and or had different frameworks. And so the English framework is very much just to give you an example of how an EPRR framework might work. You will hear how the Department of Health and Social Care developed a Covid-19 action plan in early March 2020 to provide the public with information about what the government knew, had planned for, and was planning for. And the department devised an internal battle plan, to use their phrase. Can we look at page 6, please? There's the Covid-19 battle plan from March 2020. It split the work into various work streams which are set out underneath the contain, delay, research, mitigate phases. And my lady will see there that work stream 1 was to sustain the health and social care resilience, especially critical care capacity and workforce. It was to ensure supplies to the NHS, including PPE and ventilators. There was a work stream delivering widespread testing, and work streams in relation to accelerating technology, social distancing, and shielding. My lady, the effectiveness or otherwise of this plan will doubtless be something that you will wish to consider as the evidence progresses. Now I turn to the structure in Northern Ireland. Since 1973, there's been an integrated health and social care system in Northern Ireland. The Northern Ireland Executive is composed of 9 departments, each with a ministerial lead. The Department of Health is one of those 9 and is responsible for health and social care legislation and policy. Until April 2022, there was a single health and social care board that worked in conjunction with the Public Health Agency in Northern Ireland, which commissioned services to meet, need and promote general health and well-being. And the health and social care services that are provided by 5 health and social care trusts. Can we have a look, please, at page 7? There are the 5 trusts, one in Belfast, and then north, south, eastern, southern and western. And as I said, the 6th trust provides ambulance services for the region. And my lady, the health and social care structure is different in Northern Ireland, given that in England, Scotland and Wales, provision of social services remains the responsibility of local authorities. Robin Swan was the minister at the time Module 3 is examining. And in terms of the structure, there is what is known as the top management group and the departmental board, who have responsibility for overall corporate governance of the Department of Health. They also ensure that the minister's policies and priorities are implemented. In Northern Ireland, the Emergency Response Plan 2019 was the plan that was used in response to the emergence of Covid-19. Now, that response operated under a gold, silver and bronze model, with the Department of Health operating as a gold command, setting the broader and longer-term responses to the pandemic via a strategic cell and the Emergency Operations Centre. And it was the Emergency Operations Centre that was responsible for managing the flow of information into and out of the strategic cell and between the Department of Health and Social Care sector and indeed across the wider Northern Ireland executive departments and the UK government. Under that was the Silver Command, where the bodies such as Public Health Agency in Northern Ireland, known as PHA, whose responsibilities include health protection. And during the pandemic, this entailed Public Health Agency providing SITREP data, situation reports, to the department. They maintained surveillance systems of COVID-19 cases and they looked at outbreaks. And they adapted guidance on the management of cases, to name just a few of their responsibilities. And at bronze level, which is essentially the operational level, were the health and social care trusts themselves. So although I've referred to gold, silver and bronze structure by reference to the position in Northern Ireland, there is a similar command structure operated in a number of places, including, for example, in the Welsh health boards. The Department of Health in Northern Ireland was responsible for the development and management of the Covid-19 dashboard, which included data from the trusts and analysed trends in pandemic-related data, including, for example, attendances at emergency departments, number of people being admitted to hospital, number of cancellations of elective admissions and others. The then Health and Social Care Board also coordinated a range of groups to support regional communication across Northern Ireland, including among frontline staff such as the Critical Care Network for Northern Ireland, which also developed a daily situation report informing the system of bed availability and demand by unit. And my lady, of course, in relation to Northern Ireland, although the Republic of Ireland and Northern Ireland are separate jurisdictions, from early on in the pandemic, there was collaboration with the Republic on public health policy, including arrangements for the sharing of information on infectious diseases. To Scotland. The government in Scotland is structured into a number of directorates, of which the Health and Social Care Directorate is one. The directorates and their related public health bodies are responsible for putting government policy into practice. The Scottish ministers, health boards and local authorities are all under a legal duty to continue to make provision to protect public health in Scotland. And indeed, the Cabinet Secretary for Health is under a similar statutory duty to promote a comprehensive and integrated health service. Those Cabinet Secretaries during the relevant period were Jean Freeman until May 2021, and thereafter Humza Yousaf, both of whom will be giving evidence. Very early on in the pandemic, on the 17th of March of 2020, Ms Freeman advised the Scottish Parliament that the NHS would be placed on an emergency footing for at least 3 months. And she set out that she was giving instruction to the NHS and the individual health boards to do all that was necessary to manage the expected increase in the number of cases of COVID-19. In short, my lady, this meant the strategic direction was was determined by Ms Freeman, and all of the Scottish NHS boards would follow the same set of actions, albeit the operationalisation of them may differ according to local circumstances such as geography. you will hear from the Director General of the Directorate, Caroline Lamb, who's been in post since January 2021. And the Director General has a number of roles, including having oversight of all of the health boards in Scotland. And during the pandemic, new directorates were established, such as the Directorate for COVID Health Response, the Directorate for COVID Public Health, and there was a Directorate for PPE. The Health and Social Care Directorate in Scotland provides a policy and a delivery function, as well as oversight of the NHS. The Health and Social Care Management Board is the main decision-making body of the Directorate, and its remit is to be collectively responsible for strategy and performance. Now, during the first 3 months of the pandemic, between March and May 2020, that board was briefly reconstituted to become known as the Planning and Insurance Group, which was collectively and individually accountable for the strategy, before reverting in due course back to the board. My lady may recall from Module 2A that the Scottish Government's approach to decision-making during the pandemic was set out in its framework document published in April 2020. That included suppression of the virus to the lowest level possible while seeking to minimise the broader harms. And that framework identified in broad terms 4 main ways COVID caused harm: direct and indirect health harms, and indeed social and economic harms. And whilst that framework was not a hierarchy, you will hear that preventing direct harm, namely the mortality and morbidity associated with COVID, was the Scottish Government's paramount concern. There are 14 geographical health boards and 7 non-geographical special boards that are all supported by NHS National Services Scotland, or NSS, and indeed by the Healthcare Improvement Scotland. And can I just put up on screen page 8, please? There you can see the geographical boards set out, and you'll notice immediately, my lady, the very wide spread of regions that they cover, territory that is covered, indeed numbers of people within each of those regions, and the special NHS boards are set out there. And the boards are delegated responsibilities by the Cabinet Secretary to plan, commission and deliver healthcare services and take overall responsibility for health and well-being. NSS provides strategic support. For example, during the pandemic, they provided services related to national screening programmes, many of which in fact were paused during the pandemic, in common with the position across the UK. And NSS was also responsible for procuring and delivering PPE. NSS had a public health and intelligence unit, but on the 1st of April of 2020, Public Health Scotland was established, and most of the unit's functions were transferred to Public Health Scotland. There is one important exception to that, and that was the service provided by the Antimicrobial Resistance and Healthcare Associated Infection Service, or ARHI for short. ARHI provides national expertise for infection prevention and control. ARHI's IPC guidance was published in what is called the National Infection Prevention and Control Manual, NIPCM. And that manual was first published in Scotland in 2012, and it's important because it now forms what I may call the backbone of much of the IPC guidance used across the UK today. ARHI played an important role in the UK-wide Covid-19 IPC guidance, and in particular, one of ARHI's former members, Lisa Ritchie, became the head of infection prevention control at NHS England, as she initially chaired the UK IPC cell, and it was the UK IPC cell that made the infection prevention and control recommendations that underpinned the UK IPC COVID-19 guidance. And may I just say one thing about that cell? That cell brought together IPC leads of the NHS and the public health bodies from all 4 nations. Each national representative on the cell was responsible for taking the cell's recommendation back to its respective country for approval, usually either by the Chief Nursing Officer or the Chief Medical Officer. It was not technically a decision-making body. However, you will want to consider the extent to which, if at all, the UK IPC cell's recommendations were altered and or overturned, as there may be little evidence of that. Thus, you may come to the conclusion that it's likely that the cell was, de facto, the body making the decisions in respect of the IPC guidance. The structure in Wales has the Welsh ministers who set the high-level policy framework and the targets for the health service, which are then delivered by the local health boards and NHS trusts in Wales. There is a Health and Social Services Group, HSSG, which sets out the minister's expectations in respect of planning and performance and the assurance it seeks from NHS organisations through its planning, delivery and compliance frameworks. The NHS in Wales is principally made up of different types of statutory bodies, the 7 local health boards, there are 3 trusts and 2 special health authorities. Now in Wales, the healthcare services are primarily delivered by the 7 local health boards who are responsible for planning, securing and delivering healthcare services for the benefit of their resident population within their geographical area. The term NHS Wales is commonly used to refer collectively to the local health boards and indeed the special health authorities, but unlike in NHS England, there is no central legal entity of this name. The ministers in post during the relevant period were Vaughan Gething until May 2021, followed by Eluned Morgan thereafter. And while delivery of the healthcare services is the responsibility of the NHS bodies, the Welsh ministers are responsible for monitoring the financial duties of the NHS bodies, and each board has to submit plans to the minister, setting out how they will use the funds, and those plans are then approved by the Welsh minister. At the start of the pandemic, Dr. Andrew Goodall was the Director General of Health and Social Services, also the Chief Executive of NHS Wales until September 2021, when he became the government's permanent secretary. Judith Paget took the role of Director General thereafter, and that of Chief Executive of NHS Wales. In Wales, in addition to the UK pandemic flu strategy 2011, Wales also followed a number of other plans. There are 3 in particular: the Pan-Wales Operational Response Plan from 2019, the Wales Health and Social Care Influenza Pandemic Preparedness Response Guidance issued in February 2014, and then there was the Pandemic Influenza Extreme Surge Guidance for the NHS in Wales. Now, that latter guidance had been in draft form at the start of the pandemic, was updated for Covid-19 by the Covid-19 Health and Social Services Planning and Response Group. And that planning and response group's role was to consider the reasonable worst-case scenarios for COVID risk assessment and coordinate the response of planning across Wales. Public Health Wales was part of that planning and response group, and you'll be hearing from Public Health Wales' National Director. And so that, my lady, was a very quick and summary attempt to set out some of the structures in place at the highest level of planning and preparedness across the 4 nations. At a more local level, the spotlight evidence attests to some of the plans put in place by the trusts and hospitals and the considerable efforts they went to as the pandemic struck. May I deal, my lady, with one other topic, perhaps before we turn to our mid-morning break? And it's at the outset the issue of inequalities. Laws across the UK require public authorities to have due regard to certain equality considerations when exercising their functions. And I refer to these legal duties because, as my lady knows, the inquiry's terms of reference specifically set out that the inquiry will consider any disparities evidenced in the impact of the pandemic on different categories of people, including but not limited to those relating to the protected characteristics under the Equality Act 2010 and the equality categories under the Northern Ireland Act 1998. I know that in previous modules you have heard from a number of experts who provided your ladyship with evidence about some of the many inequalities that existed pre-pandemic, which were exacerbated by the pandemic. You will recall the evidence given by Professors Marmot and Bamborough, who in Module 1 spoke, for example, of the socio-economic inequalities, such that the more deprived local authorities in the UK have worse health than the less deprived, and that those in more deprived areas have shorter lives and live more years in ill health compared to people living in less deprived areas. The expert spoke of ethnic inequalities in health, where notwithstanding the concerns about the reliability of data, there was some evidence that ethnic minority people may have much poorer health than white people. Those ethnic inequalities have particular significance in my submission for the NHS. Amongst all the staff employed by the NHS, and there are 1.3 million in England as of March 2020, approximately 21% are from a black, Asian and ethnic minority background, or to put another way, 270,000 people. That includes a quarter of nurses and over 40% of doctors. And my lady will hear about the evidence of the disproportionate number of black, Asian and minority ethnic healthcare workers. You will hear concerns that those group of healthcare workers were often deployed to the frontline roles. So they were there with direct contact with Covid-19 patients and so needed PPE that not only fit them, but took account of religious dress, facial characteristics such as hijabs or beards. You will hear, my lady, that risk assessments for black, Asian, minority ethnic workers happened too late, or not at all. You will hear that some staff in non-clinical roles, the porters and the cleaners, were not provided with PPE at all. And there is concern about the lack of engagement with groups set up to represent black, Asian and minority ethnic healthcare workers. And the communications with that group were not tailored or sufficiently tailored to those communities. Many witnesses will attest to the efforts they made to bring these matters to the attention of the respective governments and key decision makers, for example, the ministers, the chief medical officers, the heads of the departments, and indeed what steps were taken in response. You will hear about some specific examples of potential racial inequalities. May I just give two examples? During the pandemic, there were concerns about the use of pulse oximetry for COVID-19 patients being managed at home. Now, pulse oximeters can identify a drop in someone's blood oxygen level, which can be an indication, amongst others, that the person's condition is deteriorating. From November 2020, pulse oximeters were used in England to monitor patients who were well enough to stay at home, but who were most at risk of becoming seriously unwell. And concerns emerged that suggested that inaccurate and variable readings when the device was used on a darker skin were not appropriate. So, put it another way, the reading was inaccurate because it would suggest that oxygen levels were okay, when in fact they weren't, and it resulted in delays in those people potentially being taken to hospital and being treated. The NHS Race and Health Observatory conducted a rapid review of the evidence of inaccuracies in pulse oximeters, and you'll hear more about that and the observatory's other work when Mr. Nakvi, their CEO, gives evidence. During an Every Story Matters listening event, healthcare professionals from ethnic minority backgrounds recalled their own heightened concerns about personal safety and the risk of COVID-19 after learning that people from those backgrounds were more at risk. You will hear, my lady, particularly at the start of the pandemic, that formal equality impact assessments were not always carried out. A consequence of this was that health inequalities, defined as avoidable, unfair, and systematic differences in health between different groups of people, were not properly taken into account when measures to address the pandemic were designed. And this gives rise to the risk that measures would fail to mitigate health inequalities, or worse, the risk they would exacerbate them. the pandemic brought other inequalities to the fore. In their witness statement, for example, Age UK highlighted that age is the single biggest risk factor for experiencing severe illness and dying from COVID-19. Age UK point to data which suggests that even after accounting for people's health, sex and ethnicity and other characteristics, when compared to someone aged 60, the risk of dying was about doubled for someone aged 70 and almost quadrupled for someone aged 80. PPE, masks and the like, made spoken communication more challenging, particularly for patients who have additional communication needs, such as the deaf and hearing impaired, who couldn't lip read when people were wearing masks. Some autistic people depended on facial expressions to aid communication, and clearly the masks impeded them. The increased use of remote consultations impacted many people. For example, the move to remote consultations was difficult for people who spoke no English or for whom English was a second language. For older people, for those who lack confidence in their ability to accurately self-test. In the context of maternity care, there is some evidence to suggest that early in the pandemic, remote support did not work well for those who were breastfeeding. And my lady, you'll hear from witnesses called on behalf of MenCap and the Disability Charities Consortium. MenCap's CEO will tell you about MenCap's concerns that visiting guidance had on those with learning disabilities and its concerns about do not attempt CPR. I'll return to that topic later. The Disabilities Charities Consortium raised similar concerns, and they rhetorically ask this. To use their words, they want to know whether disabled people were treated, quote, as an afterthought during the pandemic. My lady, these are just some of the disparities and inequalities that emerge from the evidence in Module 3. And I know my lady will be keen to hear more about these matters as the public hearing progresses. Might that be a convenient moment for a morning
Certainly,
break?
if that suits you, Ms Carey. I shall return at 20 to 12.
Thank you, my lady. Ms Carey. Thank you. My lady, may I deal with the plan for the hearing? The plan for calling the evidence during the hearing will be to follow the patient journey through the healthcare system insofar as practically possible, hearing from those directly affected, although it may not always be possible given witness availability to follow strictly each and every stage of the journey. Running throughout that journey will be the need to understand some of the basics of how COVID-19 is transmitted and the infection prevention and control measures, IPC, needed to try and stop people becoming infected. And inevitably, when considering IPC measures, we will need to be familiar with terminology such as PPE, personal protective equipment, so that's clothing, for example, that is designed to protect the wearer, and respiratory protective equipment, normally a mask, a type of PPE designed to protect the wearer from breathing in the harmful substance. Professor Beggs, an expert in the transmission of infectious diseases in hospitals, will help us to understand the routes of transmission of COVID-19 and the ways to prevent and control transmission of the virus. Now, it should be noted that in relation to the transmission of COVID, as with many things in life, there was and perhaps remains a lack of scientific consensus. There are diverging views, each of which may be supported by a reasonable body of scientific evidence. And so anything I say, or more importantly, anything of the Module 3 experts say about infection, transmission, and consequential IPC measures cannot be taken as gospel. It can't be considered to be the only view on those matters. And importantly, and perhaps unhelpfully, you may think, there does not always appear to be consistent and agreed terminology. In addition to Professor Beggs, the inquiry has instructed a trio of IPC experts to consider the guidance and IPC in practice. Dr. Ji-Yen Shin, Professor Dina Gould, and Dr. Ben Warne will give evidence about topics and issues, including IPC measures taken to protect both patients and indeed staff in NHS hospitals. They will speak to the evolution of the Covid-19 guidelines and to patient and staff testing. And I anticipate that you will be assisted by other expert and indeed other witness evidence, for example, from the public health agencies, the chief medical officers, the chief nursing officers and others who will be able to assist on this topic. I do, however, need to cover some background at the outset in relation to transmission and IPC. The need for the inquiry to consider what was known about how COVID was transmitted arises because the consequences for the types of infection and IPC measures which were needed to be adopted and the PPE that should be worn. Covid-19, as you know, was a pathogen known as SARS-CoV-2. It's an organism that causes the disease. That became known as the WHO named it in February of 2020 as Covid-19. It's a respiratory disease transmitted through respiratory particles that contain the virus. Now, for ease, I'm going to refer to both the virus and indeed the disease as Covid-19. And as to transmission, in very basic terms, in order for a viral infection to be transmitted in humans, viable virus particles must be transported from an infectious individual to a susceptible individual. However, when the virus particles eventually reach a susceptible individual, they may not cause any infection, simply because they might not come into contact with the receptors in the nose, throat, eyes and lungs that facilitate infection. And so that means that in order for an infection to spread, infectious individuals must shed virus particles into the environment in such numbers that eventually some of those reach the receptors of the susceptible person. Now, there are various ways that a respiratory virus can be transmitted, including and often in combination with each other. And it may help us to have this simple diagram on screen. Thank you. There are three main routes. Firstly, droplet transmission. They are the larger particles from an infected person's respiratory tract, which reaches the eyes, nose, and mouth of the person. And on this diagram, they're represented by the larger orange circles. There is airborne transmission, i.e. via the air, and where the infection is spread by the dissemination of the smaller particles, the smaller orange dots, from the respiratory tract. And there is contact transmission, whether that's direct, i.e. from one person to another, for example, sneezing in someone's face, or indirectly via contact with a contaminated object or surface, such as the door handle as is depicted here, a light switch, surgical equipment or instruments that haven't been cleaned properly. Where the surface is contaminated, that is often known as fomite transmission. Now, in the case of respiratory infections, the size of the infected particle may be of significance when considering transmission. The larger sized particles, known as droplets, are generally thought to fall to the ground or the surface within about 1 metre from the source. The smaller particles are known as aerosols, and the reason that the size is important is because whilst the larger droplets are considered to settle rapidly, the smaller droplets, the aerosols, can remain in the air for longer, travel longer distances, and so are considered to be transmitted by the airborne route. When considering airborne transmission, Professor Beggs will provide you with a background to what he considers to be an historical confusion surrounding the size and behaviour of respiratory particles that are exhaled. In part, the problem is said to arise from the terminology used by different scientific disciplines to describe these particles, and the language used by the medical community is not always the same as that used by physicists and engineers. This, he states, is not merely a question of semantics. Rather, it has important implications for the IPC measures adopted, including the PPE that is used, when responding to a respiratory virus. You will hear that because respiratory viruses such as COVID have, save for when particular medical procedures are being carried out, been deemed not to be transmitted via aerosols, the result is that the IPC advice issued in the UK and indeed overseas, including that during 2020 and much of 2021, focused on prevention via the droplet and contact routes. And a classification of COVID as a droplet-borne virus also affected the ventilation requirements in healthcare facilities. Early in the pandemic, it was thought by many that droplet transmission was the dominant route. Now, that in part may have been due to the fact that the overarching strategy was set out in the UK pandemic influenza strategy from 2011. And there is an initial infection prevention guidance adapted from that flu strategy. And flu has historically been considered to be primarily a droplet-borne disease rather than an airborne one. You may hear that although a review in 2011 concluded that aerosols probably played more an important role in transmission than previously thought, droplets were still considered to be the principal route by which flu was transmitted. And the epidemiological evidence in support of aerosol transmission was considered inconclusive. The medical community's understanding of SARS, not to be confused with SARS-CoV-2, which became COVID, may have been equally influential in shaping early guidance, given the similarity between the two viruses. A belief that SARS was predominantly droplet-based, notwithstanding evidence that suggested it was potentially airborne, may also have influenced a view that COVID would behave in the same way. Now, my lady, that's not to say that the airborne route was not recognised as a possible route of transmission for COVID. The inquiry is in possession of numerous statements and documents that show that the scientists, experts and advisors were aware that COVID could be spread by aerosols. But those witnesses suggest that what was not clear was the extent to which aerosols transmitted the disease, the circumstances in which this occurred, and the relative contribution of droplet, aerosol and contact transmission. The extent to which the World Health Organization, WHO, guidance on this subject may have informed or coloured the UK's position on transmission. At the start of the pandemic, the WHO stated categorically that COVID was not airborne. By July of 2021, WHO partially accepted that airborne transmission occurred, and it was not until December of 2021 the WHO changed its stance and acknowledged that COVID could be transmitted via aerosol particles that could remain suspended in the air. That is a very brief overview of the issues that arise in relation to transmission. Underpinning what PPE needs to be worn is reference to health and safety requirements and the legal framework. Employers, as I think my lady knows, are under various legal duties to provide and maintain a safe working environment insofar as reasonably practicable. That includes preventing and controlling employees' exposure to hazardous substances, including infection at work. There is a framework known as the hierarchy of controls which should be considered by employers to help eliminate the risk. And can I call up page 10, please? There's the hierarchy of controls, which is the most effective at the top, down to the least effective. Elimination, in reality, was always going to be difficult for Covid-19 to be eliminated entirely, although clearly there was efforts made to reduce the number of people attending hospitals, GPs, and the like. You will see that PPE, personal protective equipment, is the final measure in the hierarchy. And it's obvious that given that the risk of COVID could not be entirely eliminated from healthcare settings, and the need to provide close quarter care to patients, PPE was always going to play a significant part in preventing the spread of the virus. It's likely to be uncontroversial, therefore, to state that PPE is one of the most important IPC measures that can be put in place to help prevent people becoming infected. And so Module 3 will be looking at what kinds of PPE were recommended, the legalities, the practicalities of this guidance, and in particular, the role of surgical face masks and respirators in protecting healthcare workers. My lady is going to hear much about fluid-resistant surgical face masks. I'm holding one up, but they are the blue masks that many of us wore at various times. FRSM, to give them their acronym, provide a barrier to splashes and droplets impacting on the wearer's nose, mouth and respiratory tract. And you'll see that they are not designed to closely fit the wearer's face, and the poor fit means that aerosols can be inhaled passing through the gap between the mask and the face. Because FRSM are not only worn to protect the wearer, but to prevent the wearer from infecting someone else, you may hear them also referred to as source control. Now, protection against aerosol particles requires the use of respirators which remove the contaminant from the air before they're breathed in. There are different types, many different types of respirators used in healthcare settings, but one that your ladyship will hear about most is FFP3, the filtering face piece. I have one example here. FFP3 offers the highest level of protection and is ordinarily, by which I mean in non-pandemic times, the only FFP class acceptable to the Health and Safety Executive for use against infectious aerosols in the UK. It's of a different quality of material and it fits the face with a much closer fit. The health and safety regulations require that those required to use respirators are fit tested by a competent person. The results are satisfactory and those results are recorded and available for inspection. Now, the IPC trio of experts will note that for many NHS staff, this was their first experience of using respirators and of fit testing, because prior to the pandemic, hospitals would not have tended to fit test workers who were unlikely to use FFP3 masks in their day-to-day roles. So at the outset of the pandemic, there were staff trained to perform fit testing. They were few and far between, and more NHS staff had to be rapidly trained. This resonates with evidence from some of the spotlight hospitals from whom the inquiry obtained evidence. Some of those spotlight hospitals told us they abandoned fit testing in favour of what's called fit checking, with one hospital stating it moved at one point to fit checking to avoid, quote, being overwhelmed. A fit test is not the same as a fit check, the latter of which is simply regarded as good practice to ensure the mask is being correctly worn. And fit checking is not a regulatory requirement. It is not a substitute for fit testing. The British Medical Association note, for example, that across a range of their surveys, female respondents consistently reported slightly higher rates of failing fit tests compared to males. Other research also suggests that failure rates of fit testing are higher in staff from ethnic minority backgrounds when compared with staff of white ethnicity, including in particular those with beards. One of the core participants in this module, FMHWG, report that where fit tests were failed, this did not necessarily result in more suitable PPE being provided. And so, my lady, I just want to briefly summarise what PPE was recommended for healthcare workers and when. This is by no means a reference to all of the guidance that was issued, but it's to give you an indication of some of the issues that will arise in the evidence. And may I start with the position as at January 2020. As you heard in Module 2, in January of 2020, Covid-19 was designated as a high-consequence infectious disease, or HSID. HSIDs are highly transmissible infections and are defined according to a set criteria, which includes the fact that they typically have a high case fatality rate. The CFR, the case fatality rate, is the proportion of those with symptoms and an infection who die. And you will hear that because of the mode of transmission for an HSID is often unknown at the early stages, and because certain procedures that generate aerosols are often required to be performed on HSID patients, HSIDs require a high level of PPE to be worn, but it should be noted that the mode of transmission does not determine whether a disease is an HSID or not. By the 13th of March, so 2.5 months on, Covid-19 was declassified as an HSID by the Advisory Committee on Dangerous Pathogens and indeed NervTag, and that advice was accepted by the government a few days later. Therefore, COVID was subsequently to be managed like other contagious diseases. Now, that decision was based on the evidence about COVID that had emerged between January and March, and in particular, the fact that mortality rates were considered to be low. May I just pause there to make this observation, though, about a relatively low mortality rate compared to other HSIDs, because whilst the proportion of those infected who die of COVID was known to be about approximately 1%, which is higher than seasonal flu, but lower than, for example, SARS, COVID is highly transmissible. So if lots of people get infected, even if the fatality rate is relatively low, you will still get high numbers of deaths. And indeed, as you know from the ONS statistics, a number of people did get infected, leading to that over 186,000 deaths that I referred you to at the beginning. When considering the evidence relating to HSID, it's important not to elide issues of what PPE was recommended whilst COVID was classified as an HSID with what PPE should have been recommended once it was declassified. They are two separate issues. And 2 points may arise for your ladyship's consideration. Whilst it may be that the declassification of COVID as an HSID was a reasonable decision, this did not signify that COVID-19 was not transmitted via airborne route. And equally, just because a higher level of PPE was used whilst COVID was classified, that doesn't automatically mean that the higher level of PPE for healthcare workers was no longer appropriate once the disease had been declassified. By March 2020, on the 13th of that month, the IPC guidance stated that the following PPE should be worn. FFP3 masks and disposable eye protection should be worn at all times in high-risk areas where AGPs, and I'll come back to those in a moment, are being conducted. That included intensive care units, high dependency units, where they were managing the COVID-19 patients. The blue mask, the FRSM, were to be worn by general ward staff, community staff, ambulance, social care staff for close patient contact, unless an AGP was being performed. AGPs, another acronym, aerosol generating procedures, are procedures that are thought to have a high risk of aerosol generation and an increased risk of transmission from patients with a known or suspected infection. So during AGPs, healthcare workers should wear the FFP3 respirator. They have eye protection, a disposable long sleeve gown, gloves. You will hear that there are issues relating to what procedures were designated as AGPs, and in particular concern that cardiopulmonary resuscitation, or CPR, was not listed as an AGP. That led to a divergence in approach from some bodies, including the Resuscitation Council in the UK and the College of Paramedics and Ambulance Trusts, who recommended that FFP3 was worn when conducting CPR, in contrast to the UK IPC guidance, which didn't make that recommendation. A month on, in April 2020, the IPC guidance recommended reuse and sessional use of PPE. In effect, prolonged use of specific PPE items during a single period of time when working in a specific setting. So to give you an example, wearing the same mask and goggles throughout a ward round, but still changing apron and gloves every time physical contact was made with a patient. And that guidance was brought in because there were concerns about supplies of gowns in particular, which resulted in specific guidance being issued, recommending that sessional use and reuse where there were severe shortages of supply. I jump forward to June of 2021, on the 1st of June. By this stage, IPC guidance recommended an enhanced role for local risk assessments. The guidance stated that if an an unacceptable risk of transmission remains following the risk assessment, it may be necessary to consider the extended use of RPE for patient care. The risk assessment should include evaluation of the ventilation in the area and the prevalence of infections or new variants of concern in a local area. And by March 2022, the guidance now stated that FFP3 should be used for AGPs and when dealing with cases of suspected or confirmed infection spread predominantly via the airborne route. Now, my lady, you will hear that other iterations of the IPC guidance use phrases such as spread wholly, spread predominantly by the airborne route. Not only were they considered confusing, but you may want to consider how practically useful words such as wholly and predominantly were to those who had to assimilate this guidance at short notice and disseminate it accurately to healthcare workers on the front line. You may hear evidence from some witnesses that the changes in 2022 to which I've just alluded were, to paraphrase, too little, too late. Because it appears that for much of the pandemic, and certainly up to the end of 2021, the position was that if a healthcare worker was working in an ICU or an HDU or a COVID hotspot, or they were performing AGPs, they had a higher level of PPE throughout. But for the remaining healthcare workers who made up the vast majority of the workforce, it was simply the blue FRSM masks that were recommended. You will hear that there was concern amongst the medical community that the IPC guidance did not sufficiently protect healthcare workers, particularly before vaccinations became available, and a belief that the FFP3 masks were not being recommended, save for the hotspots and the AGPs, because there were insufficient supplies of those respirators. It is argued by some that the IPC guidance was influenced by supply rather than safety. It failed to adopt what is called the precautionary principle. Now, there may also be disagreements about the precise definition of the precautionary principle, but in short, the precautionary principle describes an approach that should be adopted for addressing hazards subject to high scientific uncertainty and rules out lack of scientific certainty as a reason for not taking preventative action. During the course of the evidence, my lady will doubtless hear the phrase, "The absence of evidence is not evidence of absence," and you will need to consider whether the government agencies and those that advise them were more pragmatic than precautionary when it came to the IPC guidance that was issued. Can I deal with symptoms and asymptomatic infection? Once a person becomes infected with COVID, it takes several days, normally, before symptoms start to appear. And it is during this pre-symptomatic period, which could be hours, it could be days, where a person becomes infectious before symptoms appear. This is when the virus is incubating and individuals are most contagious. There may therefore be a period of time where an individual is infected with the virus, capable of spreading the virus without them feeling ill or realising that they are infected and infectious. Some of the terminology that you're likely to hear about will resonate from earlier modules, asymptomatic in particular. The person never develops any symptoms. And you will want to draw a distinction between asymptomatic infection, where the person has the virus and does not have the symptoms, and asymptomatic transmission, where the person has the virus and passes it on. You can be asymptomatically infectious and not necessarily pass the virus on. Put another way, just because you have it doesn't mean you transmit it. Now, you've already heard in earlier modules some evidence about what was and was not known about the extent to which COVID-19 was transmitted asymptomatically. But it appears to be accepted in the UK that the possibility of asymptomatic transmission was acknowledged early on in the pandemic by the end of January 2020. The fact and degree of asymptomatic transmission, however, was challenging for the healthcare system's response to the pandemic. For example, it caused difficulties in accurately ascertaining the number of people infected with COVID, because asymptomatic people often went untested because they didn't realise they had the virus and therefore were undiagnosed. the relatively long incubation period of the virus, which for the Wuhan variant, the first variant, was 4 to 6 days. And so high rates of asymptomatic infection meant that it was difficult to identify infected patients and staff and understand the networks of transmission. I just referred to testing, and so it may help to set the scene for consideration of this by summarising the rollout and some of the matters that will need to be examined during this module. Testing is obviously important and initially focused on testing symptomatic in patients to determine whether they had the disease and if so, what treatment they should be given. But it wasn't just important for that. Testing has an important IPC function, as for example, it enables Covid19 positive patients to be isolated. The testing of healthcare workers was rolled out on various dates across the UK from the end of March 2020, thereby enabling infected healthcare workers to be isolated and those who had a negative test returned to work. The dates when asymptomatic testing of staff also varied across the UK. And Dr. Warne will explain the challenges in determining where and how COVID-19 was acquired, as this too can affect IPC measures. In particular, it can be important to determine whether COVID-19 was acquired in hospital, and if so, the extent to which it was patients infecting healthcare workers and vice versa, patients infecting other patients, healthcare workers infecting other healthcare workers. There are challenges in determining all of those things, but notwithstanding those challenges, Dr. Warne considers it likely that the number of patients across the UK who contracted a hospital-acquired infection, or nosocomial infection as it is called, to be well over 100,000 people. The age of the hospital estate is also important when considering IPC. It affects the ability of the hospital to implement IPC measures. It also affects, for example, oxygen provision, and that is a matter that did come to the fore during the pandemic. Can I deal firstly with ventilation? In England alone, the NHS estate encompasses some 17,000 buildings, and whilst not all of those are hospital, 12% of the total estate predates the founding of the NHS. That was in 1948. Around 17% is over 60 years old, and about 44% is 30 to 60 years old. If one thinks about it, in relation to implementing IPC measures, the number of single occupancy patient rooms, the ability to socially distance in wards, to open the windows, to separate COVID and non-COVID patients are all important. And in this regard, good ventilation is key. Can I put up on screen, please, 474319 on page 11? Thank you. I just want to say one thing, a couple of things about ventilation. That's the process where clean outside air is introduced into a room space to flush out any virus, other pollutants. It doesn't completely remove all infectious aerosols in the room. Its aim is to dilute and reduce the concentration of aerosols to a safe level. And so generally speaking, the better the ventilation, the lower the concentration of COVID in the room. And if one looks at this diagram that Professor Beggs will speak to, one can see there that it's set out the position, the virus is the blue dots, but clearly an infectious person has left the room at 2:30. In looking at the top brown row, at 2:30 when they've left, in a poorly ventilated room, there is a large concentration of the virus. And even 1 hour later, continuing to the top right side of the page, there is still a fair concentration of the virus in that room. Contrast that, if your ladyship will, with the good ventilation at the bottom. It includes there the ceiling fan, a window that can be opened, a portable air cleaner in this case. There is less of it even just shortly after the infected person has left, and by 3:30, a significantly different picture painted. Now, my lady, that is obviously a simplistic diagram, but if one pauses to think about an old hospital ward with multiple beds and windows that don't open and ageing ventilation systems, one can see how important ventilation is in healthcare settings. And Professor Beggs will tell you that ventilation in English healthcare systems is governed by health technical memoranda. Those memoranda give advice and guidance on the design, installation and operation of specialised building and engineering technology for use in healthcare systems. There are similar HTMs in Scotland, and the HTMs were written before the Covid-19 pandemic. And Professor Beggs will tell you that ordinarily they prioritise comfort, odour, energy efficiency over infection. He considers the HTMs to be outdated based on the current understanding of airborne transmission and in urgent need of updating. Thank you. You can take the diagram down. Thank you. I mentioned oxygen supply issues. The impact of the ageing NHS estate on pandemic response was also seen in the capacity of the piped oxygen supply system in many hospitals. And that was a matter about which a number of the spotlight hospitals were asked. By way of example, you may recall seeing reports in the news about oxygen supply issues in Watford General. That was one of the inquiry spotlight hospitals. Now, back on the 4th of April of 2020, the hospital declared a critical incident due to oxygen supply issues. In short, the previous month, they'd wanted to undertake an urgent upgrade of their ability to supply oxygen, but unbeknownst to the hospital's trust, the Department of Health had instructed that work is stopped on bulk oxygen systems that had not been prior approved. A few days before the critical incident, there were warning signs when on the morning of the 1st of April, the alarm panels at Watford General were triggered, indicating there was high pressure in the oxygen delivery system. That matter was raised over the course of the next few days with various bodies who tried to assist in having, for example, a mobile unit delivered to Watford Hospital. But come the 4th, as a result of the critical incident being declared, approximately 60 ambulances were diverted and 7 inpatients when transferred to other hospitals out from Watford General. Now, I should add that by the end of the day, oxygen capacity had been increased, and 7 days later, new evaporators were delivered. But that is a snapshot of the types of problems caused by an ageing estate that couldn't supply the requisite amount of oxygen to the hospitals. May I turn now to some of the other matters set out in Module 3's scope, and firstly, the position in relation to GPs. For many of us, the GP is the first port of call. And at the onset of the pandemic, there were approximately 35,000 full-time equivalent GPs in the UK. But as Dr. Michael Mulholland, the Honorary Secretary of the RCGP, will tell you, there were concerns pre-pandemic that there were simply not enough GPs to meet the level of demand. Pre-pandemic, the RCGP also called for investment to increase and enhance digital infrastructure. And you may think that recommendation was rather prescient, given that the pandemic saw a significant increase in remote consultations. Module 3 has instructed Professor Adrian Edwards to prepare an expert report on the impact of the pandemic on general medical practice. One of the matters he highlights is the rise in the number of telephone appointments during the pandemic. To give one example, in England in March 2020, there were 6.6 million telephone appointments. 1 year on, there are 11.4 million. It should be noted, however, that both Professor Edwards and indeed the RCGP consider that remote consultations are not appropriate for all patients. This echoes the sentiments of many contributors to Every Story Matters, who spoke of how difficult it was to assess patients without seeing them in person. They described remote consultations as risky and worrying. The contributors said they lost valuable insights they would usually gain from in-person appointments. There were significant fluctuations in GPs' workloads during the onset of the different waves of the infection and across different parts of the country. During later stages of the pandemic, there was a need for GP staff to support the vaccination effort alongside their usual care. And there was a significant impact on GPs in relation to shielding. Staff in every general practice had to go through their systems, identifying patients who should be advised to shield. Those systems were imperfect. Not all illnesses were recorded, that would have correctly coded in a patient's records. Medications, again, which would have influenced the assessment, weren't necessarily recorded in the records. And you may hear concerns that from the outset, it was unclear who should be in the shielding group and who should not. Practices report receiving a significant number of calls from patients asking for advice on this. Professor Edwards considers that the evidence suggests that overall people's experience of accessing a GP is deteriorating. The pandemic exacerbated the problems with access. He considers there to have been a lack of pre-pandemic planning for primary care and points to a stark contrast between the lack of plans pre-pandemic with what he describes as a deluge of guidance which was then issued. I think a matter that was referred to in the video that we saw this morning. That deluge was described by one GP nurse who told Every Story Matters, "I had probably, on average, about 20 different guidelines to read on a daily basis at work. At the end of the day, we were focusing more on reading these guidelines than we were on actually actioning for our patients. It took away a lot of precious clinical time and patient experience." And Professor Edwards will also explain some of the data relating to face-to-face versus virtual appointments. But as he points out, it is not all about statistics, but the potential effect on patient care. To quote him, if I may, "General practice care is not transactional in nature, it is relational." Pharmacists are a matter that Module 3 will consider. Data suggests that in 2022, there were over 14,000 registered pharmacies and community pharmacies across the UK. And you will hear that those figures are lower than when compared with pharmacy data published in 2019 in August. Whether that decrease is as a direct result of the pressures brought to bear on pharmacies by the pandemic may be difficult to establish, but the pandemic undoubtedly had a number of impacts on pharmacies and pharmacists. The reduced access to GPs led to a surge in demand for community pharmacy services. It included a substantial increase in the number of patients seeking advice for more serious conditions or mental health issues, and it led to a rise in the number of prescriptions being issued. There were demands placed on pharmacists when the vaccine was rolled out, alongside the sector's own struggles with pharmacists becoming ill with Covid-19 and self-isolating. An indication of some of those pressures on pharmacists may be gleaned from Every Story Matters, where one community pharmacist said this: "Because doctors shut down, oh my God, it became hysteria. We had days where there was 80 or 90 people queuing outside the pharmacy." You will hear there is concern amongst pharmacists that they were overlooked and that community pharmacy was not considered alongside other NHS service providers. It led community pharmacy to not having the support it needed throughout the pandemic. And to just give you two examples, pharmacy teams were initially excluded from the life assurance scheme announced in England in April 2020, which guaranteed a £60,000 life assurance payout to families of, I quote, eligible frontline health and care staff in England who died from the virus. As originally planned, the scheme would only extend to pharmacists in exceptional circumstances. However, the government soon changed its mind and included pharmacists in the scheme, and it is worth noting, for example, that a similar scheme in Wales included pharmacists from the outset. Pharmacists consider they were overlooked in relation to PPE, where community pharmacy initially had to source its own PPE. And in May 2020, when the Department of Health launched a portal to provide access to PPE, it was only made available to GP surgeries and small care homes. It took many months until the late summer of 2020 for pharmacists to be finally allowed access to the portal. And you will hear, by contrast, that different arrangements for the supply of PPE to pharmacies in Scotland, for example, led to fewer problems accessing PPE. My lady, the feasibility of implementing IPC guidance in pharmacy settings is likely to be another feature of the evidence, along with that issue of PPE. In April, so just a month into the pandemic, 34% of pharmacists responding to a Royal Pharmaceutical Society survey said they were unable to source continuous supplies of PPE. 94% of respondents said they were unable to maintain 2 metres social distancing from other staff. And 40% of respondents said they were unable to maintain social distancing from patients. Risk assessments appear to be an issue in the pharmacy sector. There are results from a survey from the RPS and the UK Black Pharmacists Association in June 2020 that found that more than 2/3 of pharmacists and pre-registration pharmacists from ethnic minorities across primary and secondary care had not yet had access to a Covid-19 risk assessment. That was nearly 2 months after the NHS said they should take place. Can I turn to 999, 111 and ambulances? Across the UK, there are 10 ambulance trusts in England, a Welsh ambulance trust, a Northern Ireland ambulance social service, health and social care trust, and there's a Scottish ambulance service. All the ambulance trusts are responsible for provision of 999 services. In England and Wales, they are also responsible for 111 services. In Scotland, it's called NHS 24 that covers the 111 service. And in Northern Ireland, although they don't usually operate 111, they did have that service during the pandemic. The inquiry has statements from all these organisations from which a number of issues emerge. First, there was the obvious increase in calls to 111 and 999 and an inevitable impact on response times to calls and an ambulance arriving. To take just one example, the London Ambulance Service took 214,000 calls in March 2020, which was an increase on the previous month. The average time to answer rose from 4 seconds in January 2020 to 200 seconds, that's 3 minutes 20, in March 2022, and on one day in March 2020, and on the 26th of March in 2020, there was a peak where it took nearly 10 minutes to answer a call. The increase in demand on London Ambulance Service coincided with a spike in sickness of their staff, with up to 20% of their staff off sick in March of that year. There was an increase in demand for ambulances, and so the module will consider how patients were prioritised to receive an ambulance and for escalation by way of conveyance to hospital and the impact this had on the paramedics and indeed the call handlers. The prioritisation of calls received by 999 ambulance call handlers is not specific to the pandemic. There are, as you will hear, 2 triage systems used across the UK which categorise calls by colour or number, depending on the nation, and that dictates the severity of the patient's condition and therefore the target response time in which they should receive an ambulance response if one is sent at all. Those targets vary between each nation. But during the pandemic, temporary changes were made to the pathway for a patient who contacted the service with confirmed or suspected COVID. This was known as Protocol 36. And in short, if Protocol 36 applied, the patient was triaged into a lower category and had to wait longer for an ambulance response. Professor Snooks, the inquiry's expert, looked at pre-hospital care and will take you through the details of the changes and the impact in more detail. NHS 111 in England and Wales and Northern Ireland and NHS 24 provide initial assessment and triage for those needing urgent but not emergency advice and care. Unsurprisingly, demand on those services significantly and rapidly increased. And again, Professor Snooks considered the efficacy of the initiatives and the impact on the safety and quality of care provided for those ringing that service. She found a high number of calls went unanswered and considers that, in summary, although there was some merit in the use of triage tools, they were not always accurate in identifying calls that did and did not need immediate care. There are issues related to the appropriateness or otherwise of IPC guidance, and in particular, which type of mask was recommended for people working in ambulances. There are also concerns about access to and the suitability of PPE. And can I pause there and ask my lady to think about some of the realities faced by paramedics attending a patient's home and then taking them to hospital? Paramedics did not necessarily know whether the patient, or indeed anyone else in the address, had COVID-19. It was not possible to socially distance in the back of an ambulance. The patient's condition might mean it was not appropriate for the patient to wear a mask. There were often long delays outside hospitals while waiting for the patient to be admitted. As the College of Paramedics told the inquiry in January 2021, they experienced handover delays at hospitals of sometimes between 10 and 12 hours. Sometimes more. And when you think about that time of year, coupled with temperatures of -2 degrees, that was not an environment where a door for ventilation could be opened without compromising the environment for the patient. There were the additional burdens caused by the need to clean and decontaminate the vehicles. And the College of Paramedics and indeed a number of ambulance trust members reported that the disposable aprons they were provided as PPE were completely impractical, and that once outside, any spillages or pathogens that might be on them were blown into the paramedics' face by gusts of wind. I touched there on the issue of handover delays, and your ladyship will hear from Catherine Henderson, the president of the Royal College of Emergency Medicine, who speaks about the impact of handover delays on the emergency departments. She notes the harmful effects on patient care that are caused by delays in the emergency department in assessing, treating, and then deciding to admit patients. And that brings me on in the patient journey to the hospital. And it hardly needs saying that for some people, COVID took a devastating toll on their physical health, attacking as it did vital organs, the heart, the lungs, the kidneys, such that there was a significant increase in the need for more intensive care beds and staff. Now, you will hear about the attempts to increase intensive care capacity. There is no doubt that it did increase, but you will nonetheless need to consider whether there was still an inability to care for some patients in an ICU setting with the amount and type of care that they needed. Two experts, Professor Charlotte Summers and Dr. Ganesh Santharalingam, have provided an expert report, and the headlines from their report are as follows. The UK entered the pandemic with less ICU capacity, by which I mean fewer staffed, equipped ICU beds than other developed countries and healthcare systems. Figures provided by the Intensive Care Society indicate the UK entered the pandemic with just 7.3 critical care beds per 100,000. By contrast, Germany had 28.2 beds per 100,000, and the Czech Republic had 43.2 critical care beds per 100,000. The experts will tell you patients were looked after in ways that were stretched and diluted compared to usual critical care, sometimes in makeshift ICUs, sometimes far from home, but much of the time with no or limited access to their families. Think about the impact on ICU staff caring for the most seriously ill patients. Results of surveys indicate that many staff would meet the criteria for being diagnosed with a mental health disorder, including post-traumatic stress disorder. An indication of the strain that ICU was under can be seen through the lens of what is called inter-hospital critical care transfers. Now, they rose dramatically during the pandemic, and that was not because ICU patients were being transferred to perhaps more specialist care or being moved nearer to home, but as you will hear from the experts, simply because there was not enough capacity. They will tell you that the transfers are regarded as the last resort, and then if we look, please, though, at this graph on screen. This is the mean daily inter-hospital transfers between critical care units across the UK, and you have set out there the position as it was in the run-up, in the 2 years in the run-up to the pandemic, the dotted line roughly representing when the pandemic started. And you can see there the rise, particularly, for example, in early 2021, where the number of people being transferred out to a bed elsewhere rose dramatically. I'll just say one thing about the graph. It is one of a suite of graphs prepared for the inquiry thanks to the joint efforts of two organisations, ICNARC and CICSAG. ICNARC is the Intensive Care National Audit and Research Centre. It collects data from intensive care units and high dependency units across England, Wales and Northern Ireland, and CICSAG is the Scottish Intensive Care Society Audit Group, performing a similar role in Scotland. At the inquiry's request, ICNARC and SIGSAG worked together to produce a combined report of comparable ICU statistics, which will be looked at, and we are extremely grateful to both organisations for their considerable assistance. During the pandemic, there was great concern amongst the medical profession that frontline doctors would be called upon to make ethically and legally challenging decisions about which patients should be escalated to critical care in the event there was no more critical care capacity. You'll hear that for a brief period of time, the Department of Health convened a working group to consider and develop a clinical prioritisation tool to be used in the event that saturation of critical care resources was reached. One of the experts, Dr. Sundaralingam, was a member of that working group, and he will explain its work and the tool itself in more detail. In fact, the tool was stopped very shortly after it was asked to be worked on, because it was considered that critical care resources would not in fact be so stretched that the tool was needed. Now, irrespective of whether that assessment of critical care resource was correct, there are parts of the profession that felt adrift in the absence of any national guidance about how to prioritise patients in need of critical care. To many, the idea that the UK even needs to consider drafting such a tool will be unpalatable. But as, for example, the British Medical Association point out, had workable guidance been available, then in the BMA's view, this would have gone a considerable way to addressing doctors' concerns about personal or legal liability and would have helped manage moral distress. Moral distress occurs when you believe you know the ethically correct action to take, but you're constrained from taking it. It would have meant, had there been such a tool, that all healthcare professionals would have been following the same guidance. And it is clear that in the absence of national decision-making tool, some hospitals, including, for example, one of the spotlights, developed their own policies for level of care decisions where there were limited resources. And my lady, I referred to diluted care a moment ago, and one aspect of diluted care is reduced staffing ratios. Intensive care units are overseen by dedicated teams. Ordinarily, ICUs have one nurse with specialist critical care training per patient. During the pandemic, in some places, the ratios were stretched to one critical care nurse to 4 or even 6 patients, with some additional support being provided by nurses and support workers who did not have critical care skills. The chief nursing officers in the UK and other witnesses will provide evidence about the impact of those changes on the nursing profession. And the impact of the pressures on ICU, on patient care and outcomes, whilst that may be difficult to ascertain and quantify, there is evidence that suggests that the pandemic resulted in a rationing of care and or poorer outcomes. Can I pick 2 examples? You may wish to consider what ICNARC call ICU capacity strain. That is a mismatch between supply and demand, with availability of beds, staff and or other resources, and the need to admit and provide care for critically ill patients, the demand. Pre-pandemic, ICNARC reported that higher strain was associated with higher hospital mortality. And so ICNARC sought to determine whether patients admitted to an ICU during times of strain experienced a higher risk of death. The short answer is they did. The greater the mismatch between the supply and the demand, the more likely it was that a patient who was admitted to intensive care would die. As part of its work, the inquiry commissioned a research company to conduct a survey of healthcare professionals. It included GPs, A&E staff, general hospital wards, doctors, and it was asking those healthcare workers about the decisions about escalation of care in waves 1 and 2. Now, I stress it was not intended to be a representative survey, nor could it be, but it was merely to hear directly from a large number of frontline staff about the challenges they faced when dealing with escalation decisions. And can I ask, please, that we call up the survey? Can I invite your ladyship to publish the entire survey later today? But if we go, please, to page 3 in the survey. This is just from the executive summary, but it sets out there that of the 1,683 healthcare professionals from the mix of roles that were spoken to, over half of those healthcare professionals reported some patients could not be escalated to the next level of care due to lack of resources during either wave. And if you look, A&E doctors and paramedics were more likely to have been unable to escalate care due to a lack of resources. The primary reasons were lack of available beds, lack of staff. And finally, in the bottom box there, 4/5, 81% of healthcare professionals agreed that more patients were unable to be escalated during the pandemic compared to before. Over 2/3 agreed that patients who were unable to be escalated were more severely ill. That resonates, you may think, my ladyship, with the paramedic on the video this morning who spoke about the difficult decisions that he had to make. Taking those pieces of evidence as a whole, you may think there is a picture being painted not only of a healthcare system creaking at the seams, but a sense of the scale of the hugely difficult decisions being repeatedly made by healthcare workers, which affected who was escalated for treatment and who was not. Let me deal briefly, please, if I may, with those efforts to increase hospital capacity. There were nearly 900,000 admissions of COVID patients to hospital across the UK. Measures taken to increase capacity included suspending elective care, that's planned surgery, a decision that was taken in each of the 4 nations just before the UK went into lockdown. It's an undoubted indirect harm, you may think. There was the discharge decisions of those medically fit. There was the rearranging the layout of hospitals to increase the number of beds. There was the building of the Nightingales and field hospitals, increasing to staffing capacity by redeploying others to work in acute and critical wards, by introducing a temporary register for returning healthcare workers, by using trainee doctors, student nurses, trainee paramedics to help bolster the staffing capacity. And there was the use of private hospitals across the healthcare system. Those arrangements are not new, but during the pandemic, how private hospitals were used varied from nation to nation. Those measures will be examined in more detail throughout the hearing. Let me just say something about Nightingales, please, if I may. And can I call up on screen, please, page 19 of 474319. During the pandemic, there were the Nightingale hospitals in England and Northern Ireland, the Louisa Jordan, as it was known in Scotland, and in Wales, the use of planned and actual field hospitals, often used as step-down facilities. They were all set up to provide extra capacity, as modelling suggested that demand for hospital beds might be exceeded. My lady, I'm not going to take you through what can be seen on the map. There are 1 in Scotland, 2 hospitals in Northern Ireland, a number of planned and actual hospitals in Wales, and 7 in England. And we have obtained evidence from all of those who can speak to why they were set up, how they were used. It was not all that were used for COVID patients. They were not all critical care capacity. They were used in a variety of ways to carry on elective surgery, used as vaccination centres in due course, and the evidence that we will consider will look at that. Staffing capacity is clearly a matter of concern. There were high vacancy rates across all sectors of the UK going into the pandemic. Nursing levels were low, and nursing vacancy rates were high. And clearly COVID caused additional staffing pressures. For example, in England, in April 2020, figures provided by the BMA suggest that 30% of recorded NHS staff absences were COVID-related. In Scotland, there was absences that were highest in April and June 2020. In Wales, absences peaked in April 2020. And in Northern Ireland, absence due to COVID-19 was actually highest in January and March 2022. If one stands back, it appears that the UK entered the pandemic with not enough staff, was then compounded by staff absence through illness, staff being absent through shielding, staff lost because they had long COVID, and that's before one even considers the long-term impact on the morale and well-being of healthcare workers who were simply burnt out. It is little wonder, therefore, as you stated in the Module 1 report, the inquiry also heard that there were severe staff shortages that a significant amount of the hospital infrastructure in England was not fit for purpose. You said this, my lady. This combination of factors had a directly negative impact on infection control measures and on the ability of the NHS and the care sector to surge up capacity during a pandemic. The health and social care services in Wales and Scotland confronted similar challenges to England. My lady, may I pause there and invite you to consider taking an early lunch? I have a few matters I would like to address afterwards, but if your ladyship is content, and indeed the stenographer is, I'm happy to carry on for another few minutes. I'm in your ladyship's hands.
Perhaps carry on just for a few more minutes?
Certainly. Can I turn then to matters relating to death, end of life, and DNA CPRs? This is an undoubtedly distressing and painful topic when considering the numbers of people who died. The first COVID death in England was on the 5th of March. It was a little bit later in Scotland on the 13th, 3 days later in Wales, and 2 days after that in Northern Ireland. You know at the outset I said there were 186,668 deaths involving COVID-19. Can I just look briefly, please, at page 20 of the document? Thank you. And can I ask your ladyship to look at the second column that refers to age-standardised mortality rates per 100,000. It'll be appreciated that England has by far the largest population in the UK, and so as you would expect, it has a higher number of recorded deaths, but the age-standardised mortality rates allows comparisons to be made across the different population sizes, different age distributions, and you will see there that Scotland, towards the bottom of the table, in fact had the lowest rate of deaths per 100,000 at 124.9. England has 145. Wales was slightly less than that at 144. And indeed Northern Ireland slightly less at 130. As is often the case when looking at statistics, there needs to be a degree of caution, as there are inevitably caveats and qualifications. There were differences in the way that the Department of Health recorded deaths. It was initially there had to be a positive test. That was changed in due course again in August 2020. It was changed and deaths were counted as COVID deaths if the patient died within 60 days of testing positive. The availability of testing will also have an effect on how COVID was recorded on a death certificate. And of course, there was limited testing capacity at the start of the pandemic, which may mean that some patients died who may have had COVID but were not tested and therefore not recorded as a COVID death, whether by any of the health authorities or statistical agencies. Ascertaining how many healthcare workers died of COVID-19, and of that number, those who caught the infection at work, is not straightforward due to competing estimates and incomplete information. Figures from the statistics authorities across the UK indicate there have been 904 deaths involving COVID-19 of healthcare workers. Now, that figure only includes those aged between 20 and 64 and covers slightly varying time periods. Contrast that with data provided by NHS England, who, as at the 3rd of July 2023, had recorded 559 NHS staff as having died of COVID-19. It will immediately be seen that the ONS has a higher count than the figures provided by NHSE, and that is a matter of concern to some of the core participant groups. In Scotland, the health boards reported 97 staff to have died. The Welsh Government does not hold or publish official or verified data on the number of NHS staff who died. And in Northern Ireland, the Department of Health asked the Trust to provide the daily number of deaths of health and social care workers, but the department has told the inquiry it does not hold any collated data. Thank you. I'm told I've misread and I said 97 Scottish staff died. It's 27, forgive me. Thank you. We have obtained evidence about the deaths of healthcare workers from the 22 spotlights, 6 of whom reported no deaths. Some of those numbers vary because sometimes they've included the data from hospitals or trusts, not always separating each. And there are regulations, which may be a good point to deal with just before lunch, and then at least some other matters to just after. There are regulations in place that may be a way of ascertaining the number of healthcare workers' deaths. They are called the RIDDLE regulations, the Reporting of Injuries, Diseases and Dangerous Occurrence Regulations 2013. RIDDLE requires, in this context, employers to report specified workplace incidents to the Health and Safety Executive. In the context of healthcare workers in a healthcare setting, the HSE considers that those reportable incidents include cases of disease or deaths arising from COVID only when the employee has been infected with the virus through deliberately working with it, such as in a laboratory, or being incidentally exposed to the virus. Incidental exposure can occur within the healthcare setting where people are known to have COVID, known as occupational exposure. Now, evidence from the HSE notes that RIDDLE was drafted to capture single one-off unexpected events and was not intended to be used in a pandemic involving thousands of instances of infection, where an employer may be required to make a judgment as to whether the worker caught it at work as a result of workplace exposure or from the wider community. My lady will hear from a witness from the HSE who will go into this in more detail. But the HSE itself looked at the data, which was collected from the 10th of April 2020. RIDDLE reporting indicates there were 12,330 non-fatal occupational disease reports and 170 fatal reports between their reporting in April 2020 and March 2022. The HSE, unsurprisingly, have noted there appeared to be both under-reporting and over-reporting of COVID-19 by employers in healthcare settings. Now, on any view, the fatal reports are lower than one might have expected, given the ONS and indeed the NHS England figures that I outlined relating to healthcare worker deaths. And you will hear from Kevin Rowan, the head of organisation and services at the THC, which sets out their concerns about the under-reporting of COVID-19. That's a topic likely to be touched on by other witnesses as well.
Thank you very much, Ms. Carey. We'll take the luncheon break now. I shall return at 10 to 2.
All rise.